The management of urinary incontinence in women. Introduction. Urinary incontinence, or UI, is defined by the International Continence Society as the complaint of any involuntary leakage of urine. Urinary incontinence, or UI, is a common symptom that can affect women of all ages with a wide range of severity and nature. Stress urinary incontinence is involuntary urine leakage on effort or exertion or on sneezing or coughing. Urgency urinary incontinence is involuntary urine leakage accompanied or immediately preceded by urgency, a sudden compelling desire to urinate that is difficult to delay. Mixed urinary incontinence is involuntary urine leakage associated with both urgency and exertion, effort, sneezing, or coughing. Overactive bladder, or OAB, is defined as urgency that occurs with or without urgency urinary incontinence and usually with frequency and nocturia. Overactive bladder, or OAB, that occurs with incontinence is known as overactive bladder wet, or OAB wet. OAB that occurs without incontinence is known as overactive bladder dry, or OAB dry. These combinations of symptoms are suggestive of the urodynamic finding of detrusor overactivity, but can be the result of other forms of urethrovesical dysfunction. Recommendations. Management of urinary incontinence. History taking and physical examination. At the initial clinical assessment, categorize the woman's urinary incontinence as stress urinary incontinence, or SUI, mixed urinary incontinence, or urgency urinary incontinence, or overactive bladder, or OAB. Start initial treatment on this basis. In mixed urinary incontinence, direct treatment towards the predominant symptom. If stress incontinence is the predominant symptom in mixed urinary incontinence, discuss with the woman the benefit of conservative management, including overactive bladder drugs, before offering surgery. During the clinical assessment, seek to identify relevant predisposing and precipitating factors and other diagnoses that may require referral for additional investigation and treatment. Assessment and investigation. Assessment of pelvic floor muscles. Undertake routine digital assessment to confirm pelvic floor muscle contraction before the use of supervised pelvic floor muscle training for the treatment of urinary incontinence. Assessment of prolapse. Refer women with urinary incontinence who have symptomatic prolapse that is visible at or below the vaginal introitus to a specialist. Urine testing. Undertake a urine dipstick test in all women presenting with urinary incontinence to detect the presence of blood, glucose, protein, leukocytes, and nitrites in the urine. If women have symptoms of urinary tract infection or UTI and their urine tests positive for both leukocytes and nitrites, Send a midstream urine specimen for culture and analysis of antibiotic sensitivities. Prescribe an appropriate course of antibiotic treatment pending culture results. If women have symptoms of UTI and their urine tests negative for either leukocytes or nitrites, send a midstream urine specimen for culture and analysis of antibiotic sensitivities. Consider the prescription of antibiotics pending culture results. If women do not have symptoms of UTI, but their urine tests positive for both leukocytes and nitrites, do not offer antibiotics without the results of midstream urine culture. If a woman does not have symptoms of UTI and her urine tests negative for either leukocytes or nitrites, do not send a urine sample for culture because she is unlikely to have UTI. Assessment of residual urine. Measure post-void residual volume by bladder scan or catheterization in women with symptoms suggestive of voiding dysfunction or recurrent urinary tract infection. Use a bladder scan in preference to catheterization on the grounds of acceptability and lower incidence of adverse events. Refer women who are found to have palpable bladder on bimanual or abdominal examination after voiding to a specialist. In women with urinary incontinence, further indications for consideration for referral to a specialist service include persisting bladder or urethral pain, clinically benign pelvic masses, associated fecal incontinence, suspected urological disease, symptoms of voiding difficulty, suspected urogenital fistulae, previous continence surgery, previous pelvic cancer surgery, and previous pelvic radiation therapy. Symptom scoring and quality of life assessment. Use the following incontinence-specific quality of life scales when therapies are being evaluated. ICIQ, or International Consultation on Incontinence Questionnaire, BFLUTS, or the Bristol Female Lower Urinary Tract Symptoms Questionnaire, IQOL, or the Incontinence Quality of Life, SUIQQ, or the Stress and Urgency Incontinence and Quality of Life Questionnaire, UISS, or the Urinary Incontinence Severity Score, SEAPI, QMM, or the Stress-Related Leak, Emptying Ability, Anatomy, Protection, Inhibition, Quality of Life, Mobility, Mental States Incontinence Classification System, ISI, or the Incontinence Severity Index, and KHQ, or the King's Health Questionnaire. Bladder diaries. Use bladder diaries in the initial assessment of women with urinary incontinence or overactive bladder. Encourage women to complete a minimum of 3 days of the diary, covering variations in their usual activities, such as both working and leisure days. POD testing. Do not use a POD test in the routine assessment of women with urinary incontinence. Urodynamic testing. Do not perform multi-channel cystometry, ambulatory urodynamics, or video urodynamics before starting conservative management. After undertaking a detailed clinical history and examination, perform multi-channel filling and voiding cystometry before surgery in women who have symptoms of overactive bladder leading to a clinical suspicion of detrusor overactivity, or symptoms suggestive of voiding dysfunction or anterior compartment prolapse, or had previous surgery for stress incontinence. Do not perform multi-channel filling and voiding cystometry in the small group of women where pure stress urinary incontinence is diagnosed based on a detailed clinical history and examination. Consider ambulatory urodynamics or video urodynamics if the diagnosis is unclear after conventional urodynamics. Other tests of urethral competence. Do not use the Q-tip, Bony, Marshall, and fluid bridge test in the assessment of women with urinary incontinence. Cystoscopy. Do not use cystoscopy in the initial assessment of women with urinary incontinence alone. Imaging. Do not use imaging like MRI, CT, and X-ray for the routine assessment of women with urinary incontinence. Do not use ultrasound other than for the assessment of residual urine volume. Lifestyle interventions. Caffeine. Recommend a trial of caffeine reduction to women with overactive bladder. Fluid intake. Consider advising modification of high or low fluid intake in women with urinary incontinence or overactive bladder. Weight. Advise women with urinary incontinence or overactive bladder who have a BMI greater than 30 to lose weight. Physical therapies. Pelvic floor muscle training. Offer a trial of supervised pelvic floor muscle training of at least 3 months duration as first-line treatment to women with stress or mixed urinary incontinence. Pelvic floor muscle training programs should comprise at least 8 contractions performed 3 times per day. Do not use perineometry or pelvic floor electromyography as biofeedback as a routine part of pelvic floor muscle training. Continue an exercise program if pelvic floor muscle training is beneficial. Therapeutic stimulation. Electrical stimulation and/or biofeedback should be considered in women who cannot actively contract pelvic floor muscles in order to aid motivation and adherence to therapy. Behavioral therapies. Bladder training. Offer bladder training lasting for a minimum of 6 weeks as first-line treatment to women with urgency or mixed urinary incontinence. Multi-component behavioral therapy. If women do not achieve satisfactory benefit from bladder training programs, the combination of an overactive bladder drug with bladder training should be considered if frequency is a troublesome symptom. Neurostimulation. Transcutaneous sacral nerve stimulation. Do not offer transcutaneous sacral nerve stimulation to treat overactive bladder in women. Transcutaneous posterior tibial nerve stimulation. Do not offer transcutaneous posterior tibial nerve stimulation for overactive bladder. Percutaneous posterior tibial nerve stimulation. Do not offer percutaneous posterior tibial nerve stimulation for overactive bladder unless there has been a multidisciplinary team or MDT review and conservative management, including overactive bladder drug treatment, has not worked adequately, and the woman does not want botulinum toxin A or percutaneous sacral nerve stimulation. Explain that there is insufficient evidence to recommend the use of percutaneous posterior tibial nerve stimulation to routinely treat overactive bladder. Alternative conservative management options. Absorbent products, urinals, and toileting aids. Absorbent products, handheld urinals, and toileting aids should not be considered as a treatment for urinary incontinence. Use them only as a coping strategy pending definitive treatment, an adjunct to ongoing therapy, long-term management of urinary incontinence only after treatment options have been explored. Catheters. Bladder catheterization, intermittent or indwelling urethral or suprapubic, should be considered for women in whom persistent urinary retention is causing incontinence, symptomatic infections, or renal dysfunction, and in whom this cannot otherwise be corrected. Healthcare professionals should be aware and explain to women that the use of indwelling catheters in urgency urinary incontinence may not result in continence. Intermittent urethral catheters. Offer intermittent urethral catheterization to women with urinary retention who can be thought to self-catheterize or who have a carer who can perform the technique. Indwelling urethral catheters. Give careful consideration to the impact of long-term indwelling urethral catheterization. Discuss the practicalities, benefits, and risk with the patient, or if appropriate, her carer. Indications for the use of long-term indwelling urethral catheters for women with urinary incontinence include chronic urinary retention in women who are unable to manage intermittent self-catheterization, skin wounds, pressure ulcers or irritations that are being contaminated by urine, distress or disruption caused by bed and clothing changes, and where a woman expresses a preference for this form of management. Indwelling suprapubic catheters. Indwelling suprapubic catheters should be considered as an alternative to long-term urethral catheters. Be aware and explain to women that they may be associated with lower rates of symptomatic urinary tract infection, bypassing, and urethral complications than indwelling urethral catheters. Products to prevent leakage. Do not use intravaginal and intraurethral devices for the routine management of urinary incontinence in women. Do not advise women to consider such devices other than for occasional use when necessary to prevent leakage, for example, during physical exercise. complementary therapies. Do not recommend complementary therapies for the treatment of urinary incontinence or overactive bladder. Preventive use of conservative therapies. Offer pelvic floor muscle training to women in their first pregnancy as a preventive strategy for urinary incontinence. Pharmacological treatment. General principles when using overactive bladder drugs. When offering antimuscarinic drugs to treat overactive bladder, always take account of the woman's coexisting conditions, for example, poor bladder emptying, use of other existing medication affecting the total anticholinergic load, and risk of adverse effects. Before overactive bladder drug treatment starts, discuss with women the likelihood of success and associated common adverse effects, and the frequency and route of administration, and that some adverse effects such as dry mouth and constipation may indicate that treatment is starting to have an effect, and that they may not see the full benefits until they have been taking the treatment for 4 weeks. Prescribe the lowest recommended dose when starting a new overactive bladder drug treatment. If women's overactive bladder drug treatment is effective and well tolerated, do not change the dose or drug. Choosing overactive bladder drugs. Do not use flavoxate, propantylene, and imipramine for the treatment of urinary incontinence or overactive bladder in women. Do not offer oxybutynin immediate release to frail older women. Offer one of the following choices first to women with overactive bladder or mixed urinary incontinence: oxybutynin immediate release, or tolterodine immediate release, or daraphenazine once daily preparation. If the first treatment for overactive bladder or mixed urinary incontinence is not effective or well tolerated, offer another drug with the lowest acquisition cost. Offer a transdermal overactive bladder drug to women unable to tolerate oral medication. Reviewing overactive bladder drug treatment. Offer a face-to-face or telephone review 4 weeks after the start of each new overactive bladder drug treatment. Ask the woman if she is satisfied with the therapy. If improvement is optimal, continue treatment. If there is no or suboptimal improvement or intolerable adverse effects, change the dose or try an alternative overactive bladder drug and review again 4 weeks later. Offer review before 4 weeks if the adverse events of overactive bladder drug treatment are intolerable. Review women who remain on long-term drug treatment for urinary incontinence or overactive bladder annually in primary care or every 6 months for women over 75. Offer referral to secondary care if overactive bladder drug treatment is not successful, or stop the medicine and consider other treatment modalities. Desmopressin. The use of desmopressin may be considered specifically to reduce nocturia in women with urinary incontinence or overactive bladder who find it a troublesome symptom. Use particular caution in women with cystic fibrosis and avoid in those over 65 years with cardiovascular disease or hypertension. Duloxetine, serotonin norepinephrine reuptake inhibitor or SNRI. Do not use duloxetine as a first-line treatment for women with predominant stress urinary incontinence, although it may be offered as second-line therapy if women prefer pharmacological to surgical treatment or are not suitable for surgical treatment. If duloxetine is prescribed, counsel women about its adverse effects, such as fatigue. If duloxetine is prescribed, counsel women about its adverse effects, such as fatigue, nausea, diarrhea, constipation, drowsiness, sedation, headache, serostomia, or dry mouth. Estrogens do not offer systemic hormone replacement therapy for the treatment of urinary incontinence. Offer intravaginal estrogens for the treatment of overactive bladder symptoms in postmenopausal women with vaginal atrophy. The multidisciplinary team for urinary incontinence should include a urogynecologist, a urologist with a subspecialist interest in female urology, a specialist nurse, a specialist physiotherapist, a colorectal surgeon with a subspecialist interest in functional bowel problems for women with coexisting bowel problems, and a member of the care of the elderly team and/or occupational therapist for women with functional impairment. When recommending optimal management, the multidisciplinary team should take into account the woman's preference, past management, comorbidities, treatment options including further conservative management such as overactive bladder drug therapy. Invasive procedures for overactive bladder. Inform any women wishing to consider surgical treatment for urinary incontinence about the benefits and risk of surgical and non-surgical options, their provisional treatment plan, include consideration of the woman's childbearing wishes in the counseling, offer invasive therapy for overactive bladder and/or stress urinary incontinence symptoms only after an multidisciplinary team review. Botulinum toxin A. Offer bladder wall injection with botulinum toxin A to women with overactive bladder caused by proven detrusor overactivity that has not responded to conservative management. Discuss the risk and benefits of treatment with botulinum toxin A with women before seeking informed consent, covering the likelihood of being symptom-free or having a large reduction in symptoms, the risk of clean intermittent catheterisation, and the potential for it to be needed for variable lengths of time after the effect of the injections has worn off. The absence of evidence on duration of effect between treatments and the long-term efficacy and the risk of adverse effects, including an increased risk of urinary tract infection. Start treatment with botulinum toxin A only if women have been trained in clean intermittent catheterization, and have performed the technique successfully and are able and willing to perform clean intermittent catheterization on a regular basis for as long as needed. Use 200 units when offering botulinum toxin A. Consider 100 units of botulinum toxin A for women who would prefer a dose with a lower chance of catheterization and accept a reduced chance of success. If the first botulinum toxin A treatment has no effect, discuss with the multidisciplinary team. If botulinum toxin A treatment is effective, offer follow-up at 6 months or sooner if symptoms return for repeat treatment without an multidisciplinary team referral. Tell women how to self-refer for prompt specialist review if symptoms return following a botulinum toxin A procedure. Offer repeat treatment as necessary. Do not offer botulinum toxin B to women with proven detrusor overactivity. Percutaneous sacral nerve stimulation. Offer percutaneous sacral nerve stimulation to women after multidisciplinary team review if their overactive bladder has not responded to conservative management including drugs and botulinum toxin A, and they're unable to perform clean intermittent catheterization. Consider percutaneous sacral nerve stimulation after multidisciplinary team review if a woman's overactive bladder has not responded to conservative management, including drugs and botulinum toxin A. Discuss the long-term implications of percutaneous sacral nerve stimulation with women, including the need for test stimulation and probability of the test success, the risk of failure, the long-term commitment, the need for surgical revision, and the adverse effects. Augmentation cystoplasty. Restrict augmentation cystoplasty for the management of idiopathic detrusor overactivity to women whose condition has not responded to conservative management and who are willing and able to self-catheterize. Preoperative counseling for the woman or her carer should include common and serious complications such as bowel disturbance, metabolic acidosis, mucus production and/or retention in the bladder, urinary tract infection, and urinary retention. Discuss a small risk of malignancy occurring in the augmented bladder. Provide lifelong follow-up. Urinary diversion. Urinary diversion should be considered for women with overactive bladder only when conservative management has failed and if botulinum toxin A, percutaneous sacral nerve stimulation, and augmentation cystoplasty are not appropriate or are unacceptable to her. Provide lifelong follow-up. Surgical approaches for stress urinary incontinence. When offering a surgical procedure, discuss with the woman the risks and benefits of the different treatment options for stress urinary incontinence. If conservative management for stress urinary incontinence has failed, offer synthetic mid-urethral tape or open colpos suspension or autologous rectus facial sling. Synthetic tapes. When offering synthetic mid-urethral tape procedure, surgeons should use procedures and devices for which there is a current high-quality evidence of efficacy and safety, only use a device that they have been trained to use, use a device manufactured from type 1 macroporous polypropylene tape, and consider using a tape colored for high visibility for ease of insertion and revision. If women are offered a procedure involving the transobturator approach, make them aware of the lack of long-term outcome data. Refer women to an alternative surgeon if their chosen procedure is not available from the consulting surgeon. Use a top-down retropubic tape approach only as part of a clinical trial. Offer a follow-up appointment, including vaginal examination to exclude erosion within 6 months to all women who have had continence surgery. Colpo suspension. Do not offer laparoscopic colpo suspension as a routine procedure for the treatment of stress urinary incontinence in women. Only an experienced laparoscopic surgeon working in a multidisciplinary team with expertise in the assessment and treatment of urinary incontinence should perform the procedure. Biological slings. Do not offer anterior colporaphy, needle suspensions, paravaginal defect repair, and the Marchetti-Krantz procedure for the treatment of stress urinary incontinence. Intramural bulking agents. Consider intramural bulking agents such as silicone, carbon-coated zirconium beads, or hyaluronic acid or dextran copolymer for the management of stress urinary incontinence if conservative management has failed. Women should be made aware that repeat injections may be needed to achieve efficacy. Efficacy diminishes with time, and efficacy is inferior to that of synthetic tapes or autologous rectus facial slings. Do not offer autologous fat and polytetrafluoroethylene used as intramural bulking agents for the treatment of stress urinary incontinence. Artificial urinary sphincter. In view of the associated morbidity, the use of an artificial urinary sphincter should be considered for the management of stress urinary incontinence in women only if previous surgery has failed. Lifelong follow-up is recommended. Considerations following unsuccessful invasive stress urinary incontinence procedures or recurrence of symptoms. Women whose primary surgical procedure for stress urinary incontinence has failed, including women whose symptoms have returned, should be referred to tertiary care for assessment, such as repeat urodynamic testing, including additional tests such as imaging and urethral function studies, and discussion of treatment options by the multidisciplinary team, or offered advice if the woman does not want continued invasive stress urinary incontinence procedures.